I think I would like to start by saying that the CEO would have loved to be here, but due to an urgent meeting that she had to attend, she was not able to attend, but she sends words of support. So please, let's open up, let's be ready to engage and have open and frank discussions. I don't think you're new to SANAC, and I think I always like for the colleagues who are in the room who do not or are familiar with what our role and mandate at SANAC is, just to flag this to you again, because it really forms the foundation that drives some of the work that we do. At SANAC, we are responsible for developing the National Strategic Plan for HIV, TB, and STIs. And with the development of the National Strategic Plan, which you were all involved in, we also go through a process of ensuring that we develop indicators to monitor implementation of the National Strategic Plan. The new plan that was launched, the HIV, TB, STI Plan 2023 to 2028, is really remarkable because it is aligned to the Global AIDS Strategy and really seeks to address all the barriers, from structural barriers, biomedical barriers, even system barriers, because we know when we are implementing, you not only need a legal framework, a good policy framework to guide your implementation, you also need your biomedical interventions, you also need your structural, social, and behavioral interventions to be really aligned so that you can have an impact and outcome. When we develop the NSP, we also go through a process of identifying the gaps. So we cost the NSP, and this is a process where we engage with National Treasury. We cost the NSP, we find gaps in funding, and then we go through a process of resource mobilization. You'll find that we've got colleagues from the Global Fund, from CDC, PEPFAR. So in this process of resource mobilization, we try and find funds, implement strategies that will close the gap in reducing the HIV epidemic amongst the key and vulnerable populations in particular. We do not duplicate what is happening in the primary healthcare facilities. We are aligned, so we are not coming up with duplicate systems. So when we go through this process of resource mobilization and we get funds to implement our programs, we're really looking at the communities to be involved. You do know that the new NSP is a people's NSP. It's been termed the people's NSP. And so we want communities and yourselves to lead when it comes to implementing the interventions. So this is where our partners such as Global Fund, CDC, and PEPFAR come in to support the initiatives that we advocate for in the NSP. So I don't want to take too much of your time, but just to let us, think about how we can use this opportunity of this summit to identify what are the key things, what are the low-hanging fruits that we can really push forward and track implementation of to ensure that we have a meaningful response. Without further ado, Jabu, I think I want to declare the summit open. And so welcome, feel at home, and please, we encourage you to look at the agenda that has been shared. There'll be some breakaway rooms. Find an area of interest that really talks to you, that you feel, you have inputs in that particular section that, because we have the right colleagues in the room. We might not have Gugu Shabangu from DOH, but we have DOH colleagues in the room. We have PEPFAR here, we have CDC, we've got Global Fund, and we also have SANAC here to support you. So welcome everyone, and I wish you all a good and fruitful summit. Thank you.
Thank you, Gertrude. Next up, we've got Helen Sava from CDC. And just to also highlight the fact that, without the funds of CDC, we wouldn't be here today. So a special thank you to Helen for enabling us to have this meeting today. Over to you, Helen.
Thank you, everybody. And on behalf of PEPFAR, that's USAID and CDC, I just want to extend a really warm welcome to all of you today. And especially, I want to acknowledge the work of SANAC and discrimination. This has been coming up over and over and over again. We cannot get equitable services without stigma and discrimination reduction in our country. I visited Thailand recently, and it was very interesting to hear what they're doing. They're also doing key population sensitization, just like we embarked on this under the leadership of National Department of Health. They're much further ahead of us, though, with having visited one large hospital, 95% of all their staff having received sensitization training. And this is really a great achievement. Also, really holding people accountable for being sensitive to key populations and people living with HIV. So one of the things that Thai people do is they withhold bonuses if they get complaints from their recipients. It's one of the ways we could do it. I can't see it happening in South Africa, but it is one of these days. I'm also happy to say that under the leadership of Aurum and Wits RHI, Sister Pasi and Naomi, that we are doing KP sensitization with this, under the leadership of Regina Matufi, National Department of Health. We've already established 58 centers of excellence and are doing ongoing training in most of our provinces. Some provinces have been a little bit slow to come in here. But this is the core of our efforts in reducing stigmatization and discrimination in our public health services. We've got to be able to make our public health services more accessible by our key populations. We're busy finalizing the updated key population sensitization toolkit that will be endorsed by the National Department of Health. I do want to congratulate Gauteng Department of Health that have really led in the way in really absorbing key population sensitization in the province and have established a really great number of key population centers of excellence. So although we have really high quality drop-in centers like Pop-In, like Harmless, like Bereka Girl, Global Fund drop-in centers, pop-in centers, these are not scalable. Doesn't mean that PEPFAR is going away at all. It just means that they're not scalable, they're expensive, they provide high quality services, but we limit it to our geographic regions and to the number of centers. This is why we need to expand public health services to key populations in all our public facilities. So in addition to these practical interventions like the key population centers of excellence and sensitization, PEPFAR is supporting SANAC to develop and update guidelines and policies that will support the rights of all key populations in South Africa. And these include the LGBTQ+ guidelines. The last one was developed in 2017. We are updating the third sex worker national plan, and we're busy developing young key populations guidelines. All these are the core of guaranteeing rights to key populations. But we do know that more needs to be done. PEPFAR is here to support SANAC, the Department of Health, and through technical assistance, our implementing plans and our implementing partners' expertise will help develop a stronger and more sustainable approach to providing services. As we go forward today, I hope this meeting becomes a space of collaboration, shared learning, and action. Most of all, action. Together, we can raise awareness, forge partnerships, share best practices, and develop actionable strategies that will transform the healthcare landscape for key populations in South Africa. I wish you all a productive and engaging meeting. Thank you.
Thank you, Helen. Online, we are joined by Helga Musyoki from the Global Fund. She's the Key Populations Technical Advisor. Helga, are you able to hear us? She'll be joining us virtually.
Yes, loud and clear. Can you hear me?
Yes, we can hear you.
Sure. Thank you so much. Thank you, everyone, for this calling and for this great involvement, great engagement with the different partners. I'm really happy to be here. And I would like to thank SANAC for organizing this forum together with our partners, all our partners in the NDOH. I would like to say thank you to SANAC CEO in absentia and represented by Gertrude, the chair of the Civil Society Forum representative, the chief director representative, Regina, and Ms. Helen, who's just spoken. Thank you very much. Thank you all our partners, including NACOSA, Beyond Zero, and AFSA, and all our key population sectors and other esteemed delegates. Good morning. I'm really pleased to join you today for this important forum that is dubbed Framing the Key Populations Context in South Africa. And I'm really happy to be part of this greater engagement of key stakeholders, and congratulations to the country really for holding the first Key Population Forum that will be talking about great issues that have been a concern to us as stakeholders and also to the country. I would also like to thank SANAC for collaborating with the major stakeholders in the country and also engaging with NDOH to steer partners and prioritizing the key populations agenda in the HIV response. As a representative of the Global Fund, I would like to say that South Africa still remains a very important portfolio and one of the highest funded in the Global Fund. And no wonder the kind of investments that we have made considerably over the years. I would like to thank all the partners even for supporting the funding request, proposal writing, and for really burning the midnight oil to even submit the just ended funding request. And we hope that you're going to continue really to engage and have an impactful funding request in future. With the great milestones that have been achieved by the great partners that are in that room, and the great partners that are also joining online, we also must address some of the ongoing and emerging challenges with the key populations. We know there are emerging subgroups, subpopulations. We know there are emerging geographies. We know we have new data, and we have new science that is coming on board that needs to be included in our programming, our day-to-day programming. And therefore, we need to continue as partners to support the government through the various stakeholders and forums to continue prioritizing the key populations agenda, even in our national strategic plans. As Global Fund, we remain committed. And today, I would just like to highlight a few areas that are of concern and that I feel have also been a focus for this forum. And in the next 2 days, I hope we can discuss further and see how best we can move forward. Number one would be scaling up the key populations programs for impact. We know that the country has done a lot with the support of the civil society organizations. We need to move to more geographies. We need to move to the more subpopulations. We know that there are some subpopulations that have not been reached, either because of the design of the programs or because of meager resources that are also dwindling. We need to see more impactful interventions and with greater involvement of the communities. And communities would be critical in designing the designs of the programs. Where do you want your services to be? What is it that can be scaled? Which geography requires what kind of services? This is to improve the quality of services that are being provided by all the partners and key government departments, availability of these services, utilization of these services, and more so the coverage of these services, more geographies and more subpopulations. But I'm happy to see that some of these topics are topics that are going to be discussed in this forum. With the sharing of new data, we are happy to know that the country is also looking at addressing those gaps through revising the different guidelines that the country is spearheading, and we are happy to support that as partners. I also want to say that key populations continue to be the backbone of any programming in any country. And we need to see greater and consistent engagement of the key populations constituencies who are not just mere beneficiaries of the program, but can be used to provide services and be service delivery components in programming in South Africa. Would like to see more key populations programs are led by the communities, spearheaded by the communities, designed by the communities, and that is what sustainability would look like in the future. I also want to reiterate the issue of harm reduction. You know that harm reduction interventions are very key to the Global Fund. The needle and syringe program that needs to be scaled up, and that the coverage will not make an impact if we don't increase resources, if we do not have domestic discussions and have engagement of key stakeholders in the expansion of the NSP sites. We also know that we need to target some of the sex workers who are young, and the young key populations, the young MSM, the young PWIDs, young transgender, and that are crucial to the intervention that we are carrying out every day. We know that we've had limitations in the way we program for the transgender populations. And it is our call that we engage with the various government departments and the private sector to see the best models that can be provided for the South African context. Is it the private sector? What is it that we can do to work with the private sector to engage and work with the key populations that would not necessarily be supported by the national systems? We are also concerned about the expansion of the OST program. We know that the methadone prices have been very high, and this has curtailed the expansion of these programs. We also know that we also have some regulatory issues and policies that curtail and challenge the implementation of some of the interventions that are critical for harm reduction, for example, the naloxone distribution. And would want to call all the government agencies that are involved really to see how best we can remove some of these barriers and expand some of these programs to the populations that need these services. As Global Fund, we'd like to see better integration of the violence prevention and response, better alignment of the human rights violation responses, and to see how these can be institutionalized in our programs and ensure that there is sustainability. As Global Fund, again, we are concerned about the data systems, the national data systems, the DHIS, and the fact that key populations still need to be seen as part of the national strategy. We know that we have very many guidelines, we have very many strategies that are being implemented, but we still do not have a national data outlook for all partners. And we would like to call SANAC and NDOH to really spear the partners and have a national data system that speaks to all the partners and all the key populations, all the way from the community level. And that is why Global Fund is really, really supportive of ensuring that we have a strengthened outreach strategies through the microplanning TA, and we would call all other partners to support this venture so that we can have quality community data that is flowing to the national systems. Lastly, we have the domestic funding issue. And we know South Africa has done so well in terms of financing its healthcare, but we'll still see very heavily donor-funded and donor-dependent KP program. Would like to see more of government really coming in and supporting partners to scale up some of these programs. And it could start with commodities, it could start with service delivery points. And I'm glad that PEFA has been able to really spearhead the issues of integration in the public sector. But we know that not all key populations will go to the public sector. It is an option for the key populations, and we still need to have other service delivery models that can be fit for other key populations who may shy away from going to the public sector. But for sustainability, I think these are discussions that need to go forward. I look forward to having greater discussions and fruitful discussions in the sessions that are all lined up to tackle the challenges that we all have together. And together as Global Fund, we are committed to work with the government and other partners to ensure that we scale up the key populations program and we meet the 95-95 and beyond, and have a sustainable program for the key populations in South Africa. Thank you very much, and thank you really for holding this very, very important forum. Wishing you all the best, and thank you very much for the invite.
Thank you, Helga. Next up, we've got our civil society representative. We were supposed to be joined by Mr. Solindugu, but he sent his apologies, and Nonhlanhla Mkhize will be stepping in on his behalf. Thank you.
Mandla. Mandla. Viva LGBTI, viva. Viva sex workers, viva. Viva people who use drugs, viva. Viva TB ambassadors, viva. Viva everyone that is our ally, viva. Just a quick disclaimer this morning before we say too much. One, definitely not a Solindugu. Definitely not a mandate yet. We're trying to get him online so that he can speak for himself. I think it's quite important, coming from a civil society perspective, that Uslalowe, to our chairperson at the national level, speaks for himself. We would like to represent his voice. Very much myself and Comrade Thabo are part of the SANAC CSF EXCO. But I think for an occasion and a gathering like the one that we have this morning and the next 2 days, and of course the deliberations that we seek to achieve, it would really be much more appreciated to have his voice rather than ours. But should that change between this morning and this afternoon, of course we will walk in his shoes and of course present the message of support formally from the CSF, that is the Civil Society Forum at South African National AIDS Council national level. But having said that, nevertheless, as a sector leader at national, I think we're very empowered, and I'm quite excited to know that in our midst, we also have sector leaders that are serving at national. We also have provincial chairpersons of PCAs and so far as civil society is concerned that are in our midst. And of course, I want to then with that say good morning, thank you, and for having us this morning. I want to, in particular, at least from our perspective and on our behalf, acknowledge once again the presence of our comrades from CDC, Comrade Helen. As always, it's quite awesome to be having such deliberations with your input and your engagement. Madam Hilga, we've already had you speak online, and it's quite exciting that you've taken time out of your hectic schedule to join us, but also to give us some of the key things that from a Global Fund perspective, you would be looking forward to these deliberations, also taking into account. I think I would be out of order if I do not, even though in her absentia, we do not acknowledge our CEO at SANAC, Madam Umamukulu, for the support that we enjoy as civil society forum, but also as civil society sectors within the SANAC family. But I think once again, before we even get to the objectives of what this summit is all about, it's important that I once again acknowledge the presence of the national leaders, the provincial sector leaders that are in our midst, but also the organizations on the ground that are present in this in this session. I know from our partners, AIDS Foundation, NACOSA, Beyond Zero, and of course, CDC, you've already allowed some of your partners and their beneficiaries to be part of this conversation, and it is quite important that that we acknowledge your presence, and we are looking forward to hearing from you what has been your experiences, especially as people that have been implementing our programs as sectors, be it the LGBTI sector, those of you that have been implementing the MSM, the CHITI programs, be it us as sex workers, those of you that have been implementing programs as they reach and respond to our critical needs and challenges as sex workers, but also as transgender individuals, as people who use drugs, but also as people that are living with TB, if not survivors of TB currently. So I just wanted to take a moment or at least on behalf of us as sector leaders, to acknowledge your presence, and thank you very much for being here, but also most importantly, thank the partners for the financial resource in making sure that we are all here. I understand many are still not here, they're still on their way, and we're looking forward to their participation. Some are joining us on the line, so please, if there's a leader, there's an implementer that is supposed to be in this room that is not here right now, please let's find them and let's make sure that at least they are able to connect virtually, because every voice counts. And of course, you will understand that in our new NSP, we are very much people that are saying we are very much about leaving no one behind. So without any further ado then, colleagues, let's just be all on the same page about what is it that we are seeking to achieve with this summit, at least as per our objectives. Now there's only 5. All right, not a lot that we've been given to work with, and I do apologize to the language interpreter. I'm going to try to be a bit slower. There's only 5, of which the first one is really much about raising awareness. We talk a lot about key populations, but we do realize that in our different workspaces and in our different communities, not many people still understand the concept of what is it that we're talking about when we're talking about key populations, especially within a health perspective. So the hope is that at the end of our engagement in the next 2 days, whether you are here physically, whether you are online, we are all clearer on the same page, and we are able to convey the same messages when we go back insofar as implementation with our communities is concerned, about what we mean about the concept of key populations. But it's also about increasing an awareness about what are the health challenges of these communities or these populations that we're talking about when we say key populations: transgender, men who have sex with men, lesbian, gay, bisexual, people who use drugs, sex workers, TB ambassadors, but also talking into intersectionalities. And with having to raise that awareness as well, what we're hoping to achieve with that is so that in us being able to speak on the same language and being on the same page, when it comes to how we together influence policies, we will see a much different and stronger change, and much more impactful change as well, insofar as how that policy in design and implementation therefore happens. Second one is very much about fostering collaboration. You've heard these terms before. We work too much in silos, we work by ourselves in our different corners. Once again, this is a space and a summit where we want to once again foster that collaboration. No man is an island, and definitely no one organization can win this battle by itself. We all need each other. We need each other as leaders. We need each other as implementers, as programmers, as peers, as beneficiaries, if it at all we're gonna end HIV in our lifetime, or at least as we committed in this in this phase by 2013. So the idea with our summit is therefore that we foster this collaboration, that this becomes a platform where once again we commit ourselves into a dialogue, into collaborations, but also insofar as making sure that the advocacy work that we do with our different community leaders, whether political, religious, or even traditional, is such that we are all speaking in one voice. We are not taking them into different directions that they all get confused. What are these people trying to say? That in our stronger collaboration, we are all stronger in our messaging and therefore in working with them. Just the last thing is about sharing best practices. Once again, it's understanding that each and every one of us are implementers, are policymakers, are advocates, are community members. We are beneficiaries as we sit in this room, whether we are on ARVs, whether we are on PrEP, whether we are on other medications. So which means the services that our communities are accessing or not accessing, some of us are actually going through those experiences. Some of us here are accessing public healthcare services. But just for a moment, from the different organizations that we are affiliated to and the communities that we are servicing, can we use this next 2 days, especially as we go into our commissions, to make sure that our experiences have been spoken into, loudly so this time? We only have about 4 years to go towards the end of our NSP, since we've already started April 2023 and we're going until March 2025. So we have no time to waste. Those best practices need to have been discussed, shared, understood, learned, and let's see what is it that has worked best for comrades in Limpopo versus what has worked best for comrades in the Western Cape and maybe in KZN. Where are the learnings that we are supposed to be sharing with each other, whether you are working in the deep rural environments or whether you are working in much more cosmopolitan spaces? How are we, as Madame Hilga is asking, ensuring that in our partnership we are able to escalate service access, but also impact as a result, reaching those much more marginalized communities within our own key populations? Develop action plans. Now, it would be futile for us to get around the table and share best practices and forge collaborations and think big outside the box and not have a proper plans of how to action this. It is therefore the hope that as we engage in the next 2 days, we are also people who not only listen to some of the presentations that would be made, who not only engage with the content that's going to be shared, but that who are people that are going to say, from what we've heard, what we've shared, what we've learned, this is how we're gonna craft our way forward. We are already in the new NSP dispensation, but we still need a lot of things to be tweaked if at all we're gonna reach our objectives or our goals with the NSP, but also with what the communities are expecting from us on the ground. So developing action plans, formulating actionable strategies is what, from a key population summit perspective, this summit is therefore going to provide us. And I think, if I may, coming from a civil society perspective, some of you that are leaders are already aware that very soon we're gonna be having sector summits. So which means the conversations, the rich information that comes out of this room is something that needs to be on our minds as we go into individual sector key population summits, individual sector summits, because what we have taken or consumed from here needs to further inform that planning and further brainstorming, so that by the time each and every sector has fine-tuned its own implementation strategy and its own implementation plan, everything that we've discussed here has been carried through. So with that, it's also urging you once again to make sure that your voices are heard, your experiences are documented. And that brings us to the last objective of the summit. It's about empowering voices. This is a safe space. This is our space. And if we don't speak now, then who else would, or where else would we be looking forward to speak to? So please, it's our key population summit. Let's make it work for us. Let's make it work for our communities. And with that, ladies and gentlemen, and everybody else in between, including myself, in my non-conforming gender identity, welcome, and we're looking forward to a very successful summit.
Thank you so much, Ipsy. So now we're going to hand over to the National Department of Health to give us the keynote address. Ms. Gugu Shabangu couldn't be here with us. She sends her apologies. So Mary Jana Maitufi from the Department of Health will be speaking on her behalf. Thanks.
Good morning, everybody. I am Regina, as Jabu has introduced me. I'm based at the Department of Health, responsible for the key populations and the STIs. So I'm talking on behalf of our cluster manager, who was unable to come due to other pressing issues at the Department of Health. So, colleagues, as we gather at this important Key Population Summit, we want to highlight the critical role of National Strategic Plan in response to the ongoing epidemics that is faced by the key population. Most of my colleagues, they have mentioned this critical tool that we are having, that we really need to ensure that we are utilizing. So what does this tool contain? It is designed to place people and communities at the center, providing people-centered health and social services. So if we are in this gathering, we must remember all these things to say that as a Department of Health, we are also ensuring that there is a universal coverage and comprehensive response that integrate prevention, treatment, care, and support to ensure that no one is left behind. And then these responses or this intervention, they should be inclusive of the key population and ensuring that the key population, they really participate. And whatever the intervention that we are coming up with, they should be evidence-based and then they should be scalable. Our goal as a Department of Health remains to achieve ambitious 95, 95, 95 strategy. As colleagues have already indicated, we are still having challenges with our data collection, but we are going to make sure that we improve on this with the support from SANAC and also from the Global Fund, ORAM, and everybody that is in the space of assisting the department on ensuring that we improve on our key population program. And colleagues, let me also reiterate that the key populations, they are still faced with a stigma in our communities, even in our healthcare facilities. So we need to ensure that we improve on this intervention through the sensitization of our healthcare workers and also the non-clinician. We need to really make sure that everybody is sensitized regarding key population. Already Helen has mentioned that this important tool is being reviewed, and then once it is reviewed, then we will make sure that we are training, and then we are not only going to train, but we are also going to ensure that there are tools that the healthcare worker can be in a position to utilize, the algorithms are developed, and also to emphasize that we are also going to be ensuring mentoring and coaching of our health care providers regarding how to manage key population. And then colleagues, I cannot really not emphasize the importance of the young key population to say that as we are gathered here, we must also mind the fact that for us to win the battle of key population, even the young key population, we need the multi-sectorial response. Health cannot manage on itself alone, but we need to make sure that there is a broader multi-sectoral approach and multi-sectoral intervention for us to be in a position to manage the young key population. We know that health will be able to provide the biomedical intervention, but as for other determinants of health, we need social development, we need Department of Education, we need everybody in the room to ensure that we really manage our community out there. And then I have also mentioned the fact that we need a well-defined evidence based package of intervention, particularly tailored for the key population. And then as a department, we have also developed the key population health implementation plan, which was launched last year. So this key population plan, it is a guide that is meant to assist the healthcare workers to be in a position to offer comprehensive services for the key population. And colleagues, I must also say that we are also having the high transmission area, which I call it a decentralized program, which is there. And then this HTA, or decentralized key population program, it is being designed in such a way that they are hard to reach communities, they are able to access our services. It is having professional nurses, it is having the health commodities, and also the peer educators. The role of the peer educators there, it is really to ensure that they go out and look for this key population, they map and ensure that this key population, they are being referred to the services, they are being referred to the clinics for proper management. And then the other thing that as a department we are also doing is that we are also trying to make sure that our services, they are friendly towards key population. And then we wouldn't be doing that without making sure that we first start with centers of service excellence, because we want to make sure that all our key population are managed the same in all our public health facilities. That is why we are having the centers of service excellence, to make sure that we pilot so that we can be in a position to scale. And then one of the documents that as a department we have developed is a key population monitoring and evaluation toolkit. So we do have the set of data element that we have developed, and then those data elements, they are according to the key population. So we really want to make sure that they are piloted within the centers of service excellence. So colleagues, on closing, I must really emphasize that in these 2 days, we really need to kind of like engage and deeply think about the interventions that we would like to see, the change that we would like to see in improving our key population. And remember that we are having those high transmission area. So it is important to make sure that as we engage, we must look at how best can we ensure that the centers of service excellence is also talking to the high transmission area, because it is all about the key population. So in conclusion, together we can forge a path forward that ensure equitable access to services and address the pressing challenges faced by key population. I would like to thank you so much for listening to me. Thank you.
Thank you once again to speakers that spoke before me. They have set the tone for the gist of why we are here today. We've heard about the different objectives, why we are congregating today. There's also been a message around the need to prioritize key and priority populations. Once all this has been said, I think it's time for us to get into this plenary session where we are going to dig deep into some of the work that has been done around key populations. So it is going to give us an idea or an overview in terms of the state of key population programming in the country. So I've been tasked to chair this particular plenary session. So before I get into the background, may I ask colleagues that are going to be presenting to come forward? Is Mr. James Oladipo there? May you please come forward, Dr. John Steingo, as well as Sister Pasi. If you can just come to the stage and wait your turn. While they are making their way here, I think I need to give a summary in terms of what has informed this particular session. It has been noted by speakers before me that key populations are disproportionately affected by HIV. And we all know that stigma and discrimination is rife within key populations. This has limited access. So in terms of access to services, key populations, they don't have access due to stigma, which is persistent, as well as discrimination within the healthcare sector and other services. So this has necessitated the need for key population programming that is evidence-informed. So everyone was talking about evidence-informed programming and all that. So this is the emphasis of this particular session. So we'll be digging deep into what currently constitutes key population programming in South Africa, what are some of the studies that have been done, what work is being put in place to ensure that we reverse stigma and discrimination and ensure equitable access to services. So without wasting much time, I would like to call upon Ms. Jabulile Sibego from SANAC to give us an overview of the state of key populations in South Africa. So there's no better person than SANAC to give us this overview. Thank you, Jam.
Thanks, Thank you. So, colleagues at the back, I'm wondering if you can flag the presentation. And then if you can also share it online for the people that have joined virtually as well. Thanks. Sorry for the delay, colleagues. There's no location to skip slides, so I think colleagues must just do it on their sideline. Okay, maybe we can get a song in the meantime. Lela, Sukanta, Weluka, great. Tulamtana, Tulamtana, Weluka, Lela, Tulamtana.
Your slides forward and backwards.
Okay, great. All right.
So you can see your slides down there as well.
Is it? Okay, cool. All right. Okay, thank you so much. Colleagues, I'm just going to give you a background about key population programs that we have in the country. So basically, as you can all see, South Africa continues to make progress towards the UNAIDS 95-95-95 goals, and with the greatest challenge lying in the retention of our clients on arts, as well as monitoring their viral load suppression. So the national cascade, based on the Tembisa 4.6 model shows treatment coverage at 79% and viral suppression at 73%. So, as you all know, we've got the highest HIV prevalence amongst our key populations. Amongst the female sex workers, it's between 38 to 75%. Among men who have sex with men, it's 30%. With transgender women, 46% to about 63%. And people who use drugs, between 39 to 74%. And people in correctional settings, between 7 to 30%. So our key population program in the country is coordinated by SANAC, but implemented obviously by key departments, which include the Department of Health, the Department of Basic Education, the Department of Correctional Services, and the Department of Social Development, as well as PEPFAR funding, as well as Global Fund funding. But all of these are coordinated by SANAC. So if you don't know about us, this is basically a little bit of what SANAC is about. We coordinate the different government departments, civil society, as well as the private sector. And all our work is coordinated by the trust, and we also filter through all the way down through the different structures. We've got the provincial councils of AIDS, we've got the district level, we've got the ward level, and also other structures. So this slide just basically shows also that basically we coordinate the different technical task teams which look at key issues as well as technical working groups. For example, with the key populations, we've got a PWOD technical working group, we've got sex work technical working groups, we've got the LGBTI technical working groups as well, to ensure that we are having a coordinated response. So ensuring that within these technical working group structures that we include the different key partners to be able to contribute to us developing policies, strategies that create an enabling environment for our key populations. So our work is centered around the National Strategic Plan, as you're all aware. Everybody contributes towards the development of the National Strategic Plan. So there are 4 key goals that drive our response and how we address the needs of key populations. So goal 1 being to break down barriers to achieving solutions for HIV, TB, and STIs. Goal 2 being to maximize equitable and equal access to services and solutions for HIV, TB, and STIs. Goal 3 really being centered around building resilient systems and also integrated systems. And goal 4 being us ensuring that we are fully resourced and that we sustain an efficient NSP. So within the different funding streams, we've got the Global Fund. Under the Global Fund program, we've got 4 principal recipients of the grants, that being Beyond Zero, the AIDS Foundation of South Africa, the National Department of Health, as well as the Networking HIV and AIDS Community of Southern Africa, which is NACOSA. So they all implement different key population programs. So Beyond Zero implements the MSM and TG program, AFSA implementing the sex work program, and then the National Department of Health really focusing on the TB aspect of things, and NACOSA implementing the people who use drugs component. So it is a 3-year fund, and it's due to end next year. So when it comes to MSM and TG packages of services, we ensure that we provide a comprehensive package to those key populations, including the distribution of condoms, conducting risk reduction counseling, as well as assessment, to be able to structure and provide services according to the needs of the MSM as well as the TG community. And then we've got the sex work program, which also is implemented by AFSA. So basically just providing a comprehensive package of services to sex workers, but also having focused areas, which include, focusing on the clients of the sex workers, the children of sex workers, as well as young minors who are considered as sexually exploited. And then we've got the PWOD program, which ensures that it's implemented in 8 districts, offering harm reduction services as well as OST services, and risk reduction counseling and psychosocial support to people who use drugs. Then we've got the Department of Health the Department of Health's High Transmission Area Program, which Mary Jana spoke about, which ensures that we are able to control HIV, with specific focuses on reducing HIV, TB, and STIs amongst key populations, and ensuring that we've got slow HIV transmission in the general population, as well as improving the health outcomes of key and vulnerable populations. So the HTA program is funded by the conditional grants, and they do offer biomedical services as well, which include condoms, post-exposure prophylaxis, HIV counseling and testing services, and medical male circumcision, as well as looking at the workforce, the pay educators, and also offering other additional material, which has been listed there. So the Key Population Health Implementation Plan, Mary Jana also alluded to this morning, was launched in 2023. It's meant to guide public health facilities on how to provide services that are standardized for key populations. So those are the guiding principles, ensuring that key populations are part of the solution, that no one is being left behind, and that we integrate HIV programs into PHC services, and that we do no harm, and ensure that there's sensitivity and confidentiality amongst the key populations that access these services. So this is also implemented within the key population centers of excellence that she has also spoken to, and I'm not gonna go into too much detail about that because we've got a presentation from Sister Pasi on how these have been established. So we've also included some results from the Richiza report, which I'm glad my colleague James will be going into much depth with regards to those findings. And we're finding that a lot of key populations are still being discriminated against. And also what we're finding is a majority of these key populations are accessing services within primary healthcare services. So we need to ensure that these clinics are sensitized to be able to accept the community. That's just a quote from the report itself, which encourages us to ensure that urgent and drastic improvement is critical to the public healthcare system to ensure that people who use drugs, sex workers, and LGBTI community members are treated with dignity and respect and can protect their own health and lives. And the Department of Health, PEPFAR, and the Global Fund must support our public healthcare system to do much better, much faster. So as I said, there's going to be a presentation on the key population centers of excellence, so I'm not going to go into too much depth about it, but just ensuring that we have an integrated way of delivering our services and ensuring that key populations are not stigmatized. So that's just the process of how these centers of excellence are set up. I'm sure Sister Fasi will still go into that, but it's basically the Department of Health, public healthcare facilities that are identified, and meetings are convened with the facility manager, and a baseline assessment is conducted, as well as a sensitization training is offered to those gatekeepers. So this slide just shows the model of how it all operates. So there are certain standards that need to be, within the key population centers of excellence, which include making sure that clinical as well as non-clinical staff are sensitized, that there are job aids in the consulting rooms, that there are posters and peer educators or navigators within the centers of excellence, as well as representation in the clinic committees, active referrals for harm reduction services, active referral for gender-affirming healthcare services, and competent staff to provide services to key populations, and discreet and safe complaint system that is able to be recorded. So that's just the process that has been undertaken in terms of developing these or establishing these centers of excellence. I think, as I said, Sister Pasi will be going into depth about that. So within the PEPFAR program also services sex workers through different organizations, including TB-HIV-Care and VSRHI, and then there's an MSM program offered by Orem Institute, FHI 360, and ANOVA and Engagement Health, and the Transgender Women program is offered by Orem through the Pop Insights, VSRHI, people who use drugs, also TB-HIV-Care, and people in prisons. It's SA Partners and TB-HIV-Care, and I think as we go into the different group sessions, you'll be able to engage with colleagues that are that work in those organizations. So we've also got, so this slide just basically shows where the different programs operate. Okay. Sorry, I'm having glitches with mine. Okay. All right, so this slide just basically shows the comprehensive and tailored services that are offered by the PEFA program. I think all the services are quite similar in the different funding streams, so I'm not gonna go too much into depth about that. And then lastly, just to highlight some information gaps. I think we've also spoken about the fact that, you know, we don't have a national system in the country that collects key population data, but there is, you know, there are biobehavioral surveys that are being conducted, although because of limited funding, it restricts us in terms of the number of districts where we're able to operate in. So we've got the PWIT BBS, which was recently launched, which will be presented by Dr. Joel, who's part of the panel here. We've got the female sex worker PBS, which is also underway. The transgender people PBS is scheduled to happen in 2025. And the MSM BBS will be in 2026. And we've also got the BBS Lite that is also coordinated by SANAC, which will be implemented in 7 districts. So basically, we need to ensure that we are able to evaluate the key population sense of excellence, at least by 2025. And within the correctional services, we need to pilot an integration of viral hepatitis screening and treatment services, as well as piloting harm reduction services within the correctional services. On that note, I'd like to thank you for your time, for listening.
Thank you very much, Jabu, for giving the overview of different KP programs that are implemented at the benevolence of different funders. So SANAC, as we've heard, it coordinates the response by different stakeholders with the goal of ensuring that we attain sustainable health outcomes. So having heard about the different KP programs, I think it's time now to get into work that has been done to ensure that the quality of the services that we receive is actually maintained as well as being fostered within our health services. So that leads me to the project that has been done by Richidze. So Richidze, it's all about saving our lives. So it's about a community-led monitoring system that has been rolled out. And to give us more about the Richidze project, I've got James Oladipo to give us more information on that. Welcome.
Good morning, colleagues. Good morning, comrades. Can we get the slides, please? I guess while they're trying to do that, let me just give you a background of who we are as Richidze. Richidze is a consortium of people living with HIV sector organizations that have come together to monitor the state of healthcare services, mostly around HIV and TB, and services provided to members of key population in the clinics, in the community, to see how we can address these challenges. So we use, as mentioned earlier, we use the community-led monitoring model where people living with HIV, members of the key population, go into clinics, into communities to collect information, to speak to other patients, to speak to other key population on how the challenges that they are facing and how generate solutions on how this can be fixed. And through this model, we use our data and the recommendations to engage with the Department of Health and partners like PEPFAR, CDC, USAID to find ways forward. Yes, so the work we do in clinics, we monitor over 400 facilities across the country in 7 provinces. And the way we do our data collection for members of key population is slightly different because we don't go into facilities, because we very much know that you can't find members of key population in the clinic. So we run an annual key population data collection drive where we go across the country using members of key population in each district to try and find people that we can speak to find their experience. So this is what I'll be discussing today are findings from the 3rd edition of our State of Health Care for Key Population that was launched in February 2024. The data in this report was collected between July and September 2023. Sorry, the clicker is not working yet. Okay, thank you. So in this report, we spoke to a total of 13,832 people between the 4 key population group that we monitor. Over 2,600 gay, bisexual, and other men who have sex with men. About 6,000 people who use drugs, 3,700 sex workers, and over 1,400 trans people. And all the data collection tools is available on our dashboard. So one thing that was very important to highlight, and why it is very important for our clinics to be where it is safe and friendly for members of key population, is that majority use public health facilities. As you can see, the green bar shows you the percentage of members of key population that use public health facilities versus private doctors or the drop-in centers or mobile clinics. So knowing that these are places where majority go to, it is important that this place provides services that are not just friendly, but are also, respectful, confidential, and is also very accessible to members of key population. So we've been hearing about centers of excellence. For this to be workable, what we're saying is that they should be more accessible than the drop-in centers, which are the clinics being run by NGOs, to ensure that members of key population can actually get to it. They should be known, they should be advertised in communities so that people actually know that these centers exist and so that they can go there. They also should offer, the clinical expertise, transportation or transportation services for people that are far away to be able to access the services, and also some sort of referral system or referral pathway so that services that are not provided within the centers of excellence, people can be referred and be assisted on how to get to them. What we've always recommended was 2 centers of excellence per district, per population group. This means like up to about 8 of them in each district that will offer this comprehensive services. And that these services, these centers should not be exclusive to a particular population group, but whatever population group that is available can always access it. But also to ensure that these sites should also still be accessed by the general population, because it is important that there is no separation of services or separation of population, because we also don't want those centers of excellence, those clinics, to be stigmatized as places where members of the key population go to. We don't want them to be tagged as the P-Wood clinic or the sex worker clinic or the LGBTQI clinics. There should still be a lot of inclusion, and as we saw in the presentation by Jabu earlier, the inclusion model, which is what we are aiming for. And for places where people still live very far from these centers of excellence, you know, taxi fare, planned patient transport, these are some of the additional services that can be implemented. So now going into some of the key findings around staff attitude, this is something that has progressively declined in terms of, so this graph shows you staff attitude across the 4 population, across the different provinces that we monitor. And you can see people who use drugs at the most, face the most unfriendly services across board, across all provinces. And if you pay attention to all the other graphs that I will show you, you will see that the people who use drugs face the most, they receive the least services, they face the most discrimination. And it is important that not just at the centers of excellence, that even in the other clinics, facility staffs, because again, we've seen that clinical staff, you know, your nurses and your doctors, were the most that were unfriendly, followed by security guards. So that both clinical and non-clinical staff are sensitized and know that they should not ill-treat members of the key population. So around privacy and confidentiality, you can see in that reporting period, this is the percentage of people that said privacy was not well respected. You can see 74% of people who use drugs. And some of the reasons that people would give is about the fact that they disclose that you use drugs in the waiting area, more than one person is being interviewed or being consulted in the consultation room. So these are some of the reasons. And privacy violation are some of the reasons why those that stopped going to public health facilities as given to us as reasons why they stopped going. And you can see over the years that this has gotten worse. From 2021, when we first started, 2022 and 2023, you can see that it's only just gotten worse in terms of the type of privacy violations that people face. So safety and comfort. When I do my, as the researcher in charge of the Key Populations Program, I get to do one-on-one interviews with members of the key population across the country. One of the questions I always ask is, how comfortable are you in the clinic? And you know, we talk about comfort in terms of like, how can you be comfortable enough to disclose that you're a member of key population? Or how are you comfortable enough to be able to talk about the health challenges that you have as a member of a key population? How can you as a sex worker be able to explain to the healthcare practitioner that I just got assaulted by my client, I need PEP, I just had a condom bust? Or how can a gay man discuss anal sex with an healthcare worker that is either ill-informed or does not want to hear such information? So how comfortable are you to be able to disclose this when the healthcare worker you've walked into like a judgmental area, or there's like 2 or 3 nurses in there too? So you can see the percentage of members of key population that indicates that they are comfortable or they are safe within the facility. Only 4% of people who use drugs, that's 178 out of the over 6,000 people that we spoke to, feel very safe in the facility. And safe in this context, we're talking about like even safe, like you being, not being at risk of verbal or physical assault or abuse or even risk of arrest. And we know with the criminalization of some of the key population, there is also that risk. Also, a major cause of concern for us is also people that have been refused access to services because they are a member of key population. As we can see, across the different provinces where people have been refused services because they use drugs, because they're a sex worker, or because they are queer or trans. And this is people's constitutional right to health that is being violated. So it is important that this does not happen. And another thing that is also really very concerning that we discovered from last year is about people who use drugs that have been denied HIV medication, ARVs, because of various myths. I'm sure when you go into the session with Sampu, they will tell you about all of the studies that has been done that disputes this fact that people do smoke ARVs. I know this might be a bit controversial, but I would always say even if someone smokes it, you're still getting it into their system one way or the other. So at least don't use it as an excuse to deny people life-saving medication because you feel they would smoke it. Yeah, so again, what we need is that all facility staff, I think which has started already, Sister Passy would go into that, to ensure that, and I think Ellen also mentioned about the Thailand case study, to ensure that all facility staff, and this includes clinical and non-clinical staff, who ill-treat people, violate people's privacy, or verbally or physically abuse or harass members of the key population must be held accountable and face consequences. Because it seems the fact that there are no consequences, people feel like they can get away with whatever, and not realizing the effects that this causes to not just as the HIV response as a country, but also to the individuals that are being treated like that. Yes, for these centers of excellences to function, they must, be friendly and safe and confidential space for members of key population, else they would not use it. And it would be sad to invite members of the key population into a clinic that we say is a center of excellence, and they get there and still face further discrimination. That would be very sad because now we've invited them to come into those clinics, so we need to ensure that this is what we call it. And just by, we can't just label it as a center of excellence, but it needs to actually be friendly. We know sensitivity training has been going on for decades, for years, but there needs to be more, more culture change that needs to happen. It needs to be normalized in the clinics to ensure that the facility staff are able to provide the services that the members of key population need. And also, we're saying they need additional staffing that are already trained, that are already sensitized, that already have the expertise to serve members of the key population, to come into those clinics to help foster that culture change. Because people going through training might not be enough. Some people might be more open and responsive to such trainings, while others might not be. But when we have staff that come into the clinics that already have that expertise, then it's much easier to foster that culture change that we want. So, and what this, and like I said, the centers of excellence need additional staffing. And for PEPFAR, this means that, the district support partners that already employ some of these staff can, redirect them to the centers of excellence so that the centers of excellence have those staff present. And also for the national, provincial, and district Department of Health, this means ensuring that all centers of excellence recognize that, all the staff recognize that nobody is, the members of key population that are coming into the clinic do not belong to the DSP staff alone. Everybody, should be able to attend to them and provide the friendly services. I remember, and also to ensure that the facility managers and leadership have a buy-in into this concept of having their clinic or their facility as centers of excellence. I remember this training I attended with some of the members from facility managers, and one person said, "Oh, why don't we train those that are interested in this kind of concept?" And it was very good to hear the response from the National Department of Health that this is not about one person or whether you like it or not. This is a directive that is coming right from the National Department of Health for every clinic to implement. So that was very good to hear, that it is not about whether you have passion for it or whether you are interested. You're attending to human beings, so you should be able to ensure that you get on board or you get out. And then coming to the actual services that members of key population go into the clinics to access. Basic HIV prevention tools like your condoms, both external and internal. These are observations done in the facilities that we monitor. You can see there's here about 461 facilities monitored. We can see that external condoms are more readily available compared to internal condoms. At the facilities. Lubricant, some of the facilities did indicate that they do provide lubricants for HIV prevention, but in actual sense, only about 37% of them actually had lubricants in their facility, and there's 24% of those sites say you have to ask for them. And knowing the stigma, or the bias towards lubricants that is being, it's being used more by members of the LGBT community, a lot of people would not feel comfortable to ask about it. I still spoke to a trans woman recently where she said, I know there is lubricants in the facility, but you have to ask the nurses in the consultation room. And I can't do that because they already asked me so many uncomfortable questions around how are you going to use it, how do you do this? And we must remember that lubricant is for everybody. It makes sex enjoyable and safe for everybody. So it shouldn't be something that should be stigmatized or should be ordered by healthcare practitioners. Yes, we understand there is a lot of stockage around lubricants, but most of the provincial Department of Health has committed to ensuring that there is lubricants readily available in the facilities. It is also important that lubricants are placed in private spaces where people can pick them without the fear of being seen or being judged for taking them. PrEP access at the facilities, I think positively, PrEP access has increased in all the facilities that we monitor across the country, and most of the facilities do indicate that they prioritize, offering PrEP to members of this population. But it is also, how do you offer a service to someone that cannot disclose to you that they are part of that population? So, given that members of key population might not be comfortable to do this, including PrEP talk in discussion during in the mornings in health talks, having PrEP posters around the facilities is very important to ensure that the uptake of PrEP amongst members of key population that are HIV negative can be able to uptake it, and also the adequate education around PrEP. And the benefits, so that people can actually make informed decisions with uptaking them. So going into gender affirming care, in this report, we can see that 32% of trans people we interviewed said staff were always respectful. 46% said only sometimes, and 19% said staff were never respectful. And these are issues around using the wrong pronouns, not addressing them by their preferred name, are some of the ways in which trans people feel like staff has not been respectful of their gender identity. I spoke to a trans woman in Northwest, and she indicated that she's not able to use the bathroom in the facility because if you try to go into the female bathroom, either the other patient or the cleaner will tell you can't go in there. So she either goes to a friend's bathroom around the area or ensures that she holds it in until she gets home. You understand, we need to ensure that simple things like allowing trans people to use the bathroom that they prefer or having gender-neutral bathrooms in the clinics to ensure that trans people feel safe and not feel judged in the facility. And also service delivery points for men. This is a concept that was implemented for cisgender men to be able to feel comfortable in the facility to access services with so much success. But no trans woman should be made to use this service point because not only does he out them as trans, he also puts them in line of fire to face transphobia, and we know how much transphobia and transphobic attacks that trans people face and other gender diverse people face in the country. So yes, and we've realized that one of the follow-up questions to this is around like, when they ask you to do it, what did you do? You know, some are forced to do to go to those services, and they are faced by male healthcare practitioners that are very uncomfortable to also attend to a trans person. They are faced by other patients in that area wondering, what is this woman doing here? I thought you said this is a service point for men only. So it is important that trans women are not made to use service delivery points for men. Trans women are women. And yes, also around the availability of gender-affirming services for those that need it is really critically important to ensure that aside the standard general package that trans and gender diverse people might want in facilities, some might also want hormonal therapy. And as you can see, a lot would also want to access it in clinics. Currently, it's been available in like tertiary facilities in most big cities. So this also just like shows the continued divide between people in the rural areas and people in the urban areas, because I spoke to a trans woman in Tata that spoke about the fact that she can only access hormones in East London, and she doesn't have the funds to go to East London to go start up the services. So we need to ensure that services like hormonal care is available in the primary health care. Newer needles and safer injecting equipment, knowing that the benefits of using a new and quality needle every time. We know the benefits of it from wound protection, the risk of endocarditis, hepatitis, and HIV. It is important that people who inject drugs are able to access the services. But as you can see, only 9% of people who use drugs that we spoke to said they could actually even get information. We know it is not accessible in the clinics, but even to be able to provide them with information of where to get it, only 9% was able to get that. It is also important that we can also use the clinics as safe spaces where people who inject drugs can dispose safely their injecting equipment and their needles to ensure that we can avoid litter in our parks and in our communities. And also medically assisted treatment for people that might want to safely either stop, reduce the use of drugs. It is important, like methadone, to ensure that people that are on opioids are able to either stop or reduce using drugs. Again, this is not available at our primary health care or even within the health system as well. But again, only 10% of people who use drugs we spoke to were able to get any information on where they could actually even get this. It is important to know that in private, methadone is a very expensive medication to get. So it is unrealistic if we want the success of the program to expect people to be able to access it. And there's such very few harm reduction sites that actually do provide methadone for people within the communities. Naloxone, which is like an life-saving opioid overdose medication, can only be administered by a healthcare practitioner. And we don't understand the logic behind this, as most people don't overdose closer to the clinics. You might not be able to get the person closer to the clinic. We've had reports of where people call the ambulance and they can't get to the hotspots where the person is overdosing on time. And I spoke to a man who uses drugs in Katlehon, and he spoke about the fact that his friend was overdosing and they could not get him to the clinic on time, and he passed away. So we need to ensure that we change the policies around this to ensure that community members that use drugs, family members of people that use drugs, can administer naloxone to ensure that we can save the lives of people that overdose. Drug dependency support and other psychosocial services also needs to be made available. In 24% of the people who use drugs that we spoke to wanted to access those services, but only 16% of them were actually able to access them, because some of the reasons is about, like, the services is not offered, people are not comfortable to ask for it, or they were told that they were not eligible for it. And we must remember that using the harm reduction principle, rehabs are not necessarily the only solution to people, for people that use drugs. There needs to be other sort of support and psychosocial services that needs to be provided to people who use drugs, and also to ensure that people are comfortable enough to ask for these services when they want it. Also, for in a country as South Africa, where gender-based violence against sex workers is very rife, it is important that people are able to access these services that are dignified when they do experience any violence. So basic services like counseling, STI screening, emergency contraception, etc. should be available. That is also very respectful. So in rounding off, in terms of the things that we need, again, the specific services for the needs of members of key population should be made available in public health facility, starting with the centers of excellence. I'll go to some of the minimum package of services that we did indicate. HIV prevention tools, your condoms, your lubricants, this should be basics. They should be readily available. People who use drugs should be able to access the harm reduction tools that they need, your needles, your safe disposal equipment, methadone, naloxone, etc. Also, that methadone program should be made available in public health facility. We can start this with the centers of excellence, or the department can, outsource this to organizations that already provide such services, that have the expertise. And also for our facilities to be to provide gender-affirming services, so that trans and gender-diverse people are able to access the services that they require, and also to ensure that we remove. We shouldn't at this time still be having trans women being given blue folders, or being given folders that mark perceived gender identity, and to ensure that in the primary health facilities, hormonal therapy can be provided. And just again, what I had mentioned earlier with regards to ensuring that additional staffing with the expertise is needed, minimum package of services, clinicians need to understand the unique needs of and concerns of members of the LGBT community, sex workers, and people who use drugs, and to ensure that the harm reduction services are available. And these are just some of the package of services that we indicated for the different population groups. Thank you.
Thank you, James, for that presentation. So we normally have the State of the Nation address, and Comrade James gave us the State of Healthcare address. So thank you for that. So this presentation, actually, it fulfilled the need for evidence in the programming around key populations. So now it is our responsibilities as implementers, as service providers, to use this particular data to improve the way we do the work that we do, as well as to advocate for ideal services. So thank you for that, Comrade James. Without wasting much time, may I please welcome Dr. Joe Steingo, just to give us a presentation on the Biobehavioral survey, which was conducted last year, focusing specifically on people who inject drugs. So as a background, what we call BBS, or biobehavioral surveys, they provide a specific population level data in terms of burden around HIV, as well as the risk factors and coverage for prevention program. So Dr. Joe will give us what they unearthed with their survey. Thank you.
Good morning, everyone. I'm just going to try. Sorry. Are you able to hear me? Thank you. So thank you very much for that warm introduction. And I always feel quite emotionally overwhelmed when I'm here and I see all the faces, the usual suspects and some unusual ones. I think, I use that for those of people who have heard me present on this before. I maybe overuse the term preaching to the converted. So I hope I'm not preaching to. Well, in many ways, I hope that most of us are converted. But for those of you that aren't, I hope that we can convert you today to fight the cause for us, with us, Yes, I think we're still waiting for my presentation. I've got it up here, and I think my first slide, I think the concept of biobehavioral surveys has really been kind of introduced to you already, but for those of you that are unfamiliar with what a biobehavioral survey entails, I'm going to maybe give you a little bit of a background about what this biobehavioral survey in people who inject drugs is. So BBSs, as they are known, and I think Jabu also introduced them briefly earlier, are surveys that collect biological and behavioral data to understand the epidemiology of diseases and the associated risk factors within key populations. So these surveys are particularly important in key populations that are at high risk for HIV, and we collect data on biological markers. So in this biobehavioral survey, we focused, of course, on HIV, but we also looked at other infectious disease markers, so at viral hepatitis, which we know is very important in people who inject drugs, at syphilis, at tuberculosis, and then the behavioral data included interviews with participants to gather information around behaviors that increase risk for infection, so bloodborne and sexually transmitted infections. And in this population, of course, included drug use practices and as well as barriers to services, many of which James has highlighted, which prevent people from accessing the services they need. So, and I've got my slides open as well. I think I've gone one step ahead on the presentation. Sorry, everyone. Not doing a great job of the mic. Apologies. It is working. There we go. I think. Can you hear me at the back, or at the front even? Oh, okay, great. So wow, that's a lot louder. Great. Can we please just go back one more slide? I just wanted to please go through the objectives. Sorry. Oh, here we go. Okay, great. There you go. Okay, fantastic. So so the primary objectives, as you can see on the slide, of the PWOD BBS were to estimate the HIV prevalence amongst this population, to assess progress towards the 95-95 targets, to estimate the proportion of people who inject drugs living with HIV on antiretroviral therapy, to estimate the proportion that were, by our definition, virally suppressed, although we looked at viral loads less than 1,000, and to estimate the population of people who inject drugs in the 3 districts that we surveyed. And I'll show you that in upcoming slides. So you can see some of the secondary objectives, to look at service uptake, to establish serostatus knowledge, to estimate the prevalence of other infectious diseases that are important in this population, to identify risk factors, and to examine the intersectionality between drug use and behavioral and other factors and barriers. There we go, okay. So This slide just shows the geography of where we surveyed our populations. And biobehavioral surveys really are part of the intention of doing them serially is to look at trend data. And so while I'm not going to really look specifically at trends over time today, and I'm going to look at the results from our biobehavioral survey, PEPFAR and through CDC does fund biobehavioral surveys every 3 to 5 years amongst key populations. And Jabu did show us earlier that we are currently doing a survey in female sex workers this year. The one we did with PWOD was last year, 2023. And we will be doing a BBS in transgender populations next year. But the one that we conducted last year was in 3 districts, in Tshwane, in Gauteng, in eThekwini, KZN, and those are really big metropolitan areas, of course. And then Mbombela or eThekwini district in Mpumalanga is a kind of a more semi or peri-urban, semi-rural kind of area. And we wanted to try and collect data on populations in a less metropolitan area as well. You can see that Dr. KK, Dr. Kenneth Kaunda in Northwest is depicted on the slide there. But we did some formative work there and then settled on the other 3 districts for the main survey. And the number of participants that you can see there that we surveyed was based on kind of prior estimates on population size, on prior prevalence estimates, and to try and power our study adequately so that we could reach what we call convergence, so that it becomes an extrapolatable data, so that we can extrapolate beyond the sample and therefore give kind of adjusted population estimates for these districts. So you can see the eligibility criteria there. People needed to be 16 years or older. They needed to have been injecting drugs, of course, for non-medical purposes in the past 6 months was the criterion we used. We wanted them to have resided or worked in the survey locations, though unfortunately, of course, many of these people are not working. And then, of course, to consent and be able to communicate with our study staff in English or another local language. So I'm not sure how well this projects, but in biobehavioral surveys, the way that we recruit people into the survey is through a technique called respondent-driven sampling. And this just gives you kind of a graphical depiction of how that works. So what we do is we purposively recruit a number of what we aim to be kind of well-networked so-called seeds, and we want diverse seeds in terms of where they live in the district, in terms of their age, in terms of their kind of social networks, so that we can get a diversity of participants. And then those seeds are given what we call coupons, and they distribute coupons to their peers. When their peers come in and enroll into the study, they are also given coupons, and then they distribute those peers within their networks. And so in this way, we're able to reach hard to reach people who kind of via traditional recruitment methods we would find more difficult to reach. So we get a good representation of the study population. So that's called respondent-driven sampling. And those are just some of the examples of the recruitment trees. And you can see the seeds at the top of the trees. In eThekwini, for example, you can see that first seed was not as productive, as we call it, but the second one was very productive and managed to get kind of a very wide network of people to enroll into the study. Okay, so to go through some of the key outcome measures, we looked at HIV prevalence and population sizes. And I tend to overuse this word as well when I look at this data, but this is very alarming data. And I think we know it, but it really does, every time I look at it, it kind of frightens me a little bit. So if you look at the HIV prevalence, Oh, and just to say, within Etlanzeni, we had a satellite site in a small town called Mashisheng as well. So you'll see there that there were 4 sites, eThekwini and Tshwane, the 2 metropolitan sites, Mbombela in Etlanzeni, which some of us may still know as Nelspruit, and Mashisheng is a much smaller town, about 2 hours northeast, I think, of Mbombela, which we used to know as Leidenburg as well. So you can see it's smaller. But if one looks at those HIV prevalence statistics, and these are adjusted population estimates, so based on the fact that we reached, as I said, what we called convergence, which means that these are extrapolatable data, we are estimating that between 30 and 72% of our PWID, and I think that's consistent with what I think James presented a little bit earlier in the PWID population, are HIV infected, or people living with HIV. We can see the population sizes are not massive, and as a percentage of the general population are small, but we know how important it is that people that are part of these communities are very stigmatized, struggle to reach, struggle to access health services, and beyond the struggles that they face, they are also integrated within the general population and interact with the general population. And if we are not going to get epidemic control within our key populations, we are never going to attain epidemic control in the general population either. So this slide is maybe a little bit of an indictment on our services, and really looking at the progress towards the 95 targets, we can see that there are gaps. I mean, the main message in this slide is to show that there are still major gaps in our attainment of these targets. So we're looking towards 95, and you can see the large gaps there. I think they're fairly self-explanatory across all the sites. I think the silver lining on this slide is to say that there are kind of areas, geographical areas, and particular targets. So you look at the second 90 in Etlanzeni, Mbombela and Mashisheng, you look at the third 90 in Tshwane, and you can see with the programmatic support, and I forgot to mention right at the beginning that this is funded by CDC, PEPFAR through CDC, and through the programmatic support, through funding from CDC, there are pockets of communities, if I can say, that we are doing well for, and that we are managing to kind of at least get close to the 95 targets on some of the indicators, but we've got a long way to go. And I think this is kind of hard evidence to show that. So we know this through programmatic data, we know this through some of the CLM that Richitzi has presented today, but this is hard data to show that we've got a long way to go. So here's some of the other biomarkers. So we looked at, apart from HIV, we looked at TB, we looked at viral hepatitis, and we looked at syphilis. So you can see, I mean, a lot of these, let me go back. So a lot of these are quite difficult to accept, but some of the ones that that I specifically wanted to highlight, if we look at eThekwini, it looked like there was certainly a TB outbreak of some kind, perhaps, that was going on at the time that we did the survey, which was, I also didn't mention, between May and September 2023. So 7.2% of people were gene expert positive on sputum. Hepatitis B, surface antigen, which is a marker for active hepatitis B infection, nearly 6% of people had hepatitis B. More alarmingly, though, of course, is the epidemic of hepatitis C in people who inject drugs. And this is a curable disease with 3 months of treatment. And people, and look at the prevalence of hepatitis C. We can see in Tshwane and Mbombela, 90% of people had, so hepatitis C antibody is not a marker of active infection, and in fact we only did test for antibodies, but this is a marker that people have either had or do have active hepatitis C. And of course, with the HIV prevalence that we saw in an earlier slide, that means that the co-infection of HIV and hepatitis C is also massive and really very, very worrying. And of course, we know that HIV and hepatitis C exacerbate one another. So people who are HIV infected and have hepatitis C deteriorate more rapidly and vice versa as well through those disease processes. So I wanted to move on to some of the prevention indicators, and this talks again to access to health services, to people who have used sterile needles and who have used condoms and lubes at their last sexual encounter. I think, sorry, not lubes, this is just condom use. But you can see that a large-ish percentage of people had used sterile needles, but given the massive prevalence of blood-borne infections in this population, we know that they're not getting consistent and sustained use of sterile needle, of sterile equipment. And I think a similar thing could be said for condom use. So of course in people who inject drugs, I think primarily transmission routes are through the sharing of needles. But you can see there again that there are certainly gaps in these prevention indicators as well. PrEP uptake, this was for me a very telling finding. So these are the questions that we asked as part of the behavioral survey, well, as part of the interview. And so you can see here, while the majority, or at least a large proportion of people are willing and actually want to take PrEP, you can see compared to that proportion, the number of people that have actually taken PrEP in the last 12 months is really, really small. So we know it's a challenge for people who inject drugs to sustain their PrEP. They have enough going on in their lives for PrEP perhaps not to be a priority for them, but the fact that they're willing and would like to actually take PrEP, and we're looking at between kind of like, well, 50, 60, up to 67% in Mashisheng wanting to take PrEP, and between like kind of 4 and 8% actually taking PrEP in the last 8 months. That's again an indicator that access to health services is really inadequate for our key populations. So social enablers and the 10-10-10 targets are as important as the 95-95 targets, and we know that if we don't address these, by 2025, by the way, is when we want to have addressed these by, and I think that's a little bit too near into the future for us at this point. But for those of you, and I guess that most of us now are familiar with these targets, but by 2025, we would like for less than 10% of countries to have punitive legal and policy environments that deny or limit access to services. And we, of course, are very far off that. And if we look at the rest of sub-Saharan Africa, or the world, we're very far from that. Less than 10% of people living with HIV in key populations will experience stigma and discrimination. And less than 10% of women, girls, people living with HIV in key populations will experience gender inequality and violence. And sadly, as these slides are going to show, we are very far from achieving these. So we asked about engagement as part of the interview, engagement with the criminal justice system. I think it's projecting better for you than it is for my aging eyes on this screen here, but just if you look across this table, it's all fairly, I'm losing adjectives to describe this, but fairly scary data. But some of the ones that I wanted to highlight is if we look at people who had been arrested for injecting drug use in Tshwane in the last 6 months, I think I can see it, but it's 40% of people who had been arrested. And we know that when people are arrested and they're put in holding cells and then they're going to remand awaiting trial, they lose access to whether they're on opioid substitution therapy or whether they're on antiretrovirals or PrEP. All that movement between police holding cells and into correctional services, back into the community court, they interrupt whatever access to treatment or prevention services that they have. A history of incarceration, we can see in eThekwini, 62% of people had been incarcerated. And the same story there. Correctional services are doing a lot of work now to try and integrate, and I think Jabu alluded to that as well, viral hepatitis services through support, through PEPFAR and CDC support, viral hepatitis services, OAT services, but it's still very much in the kind of initiation phases of that. And so people are interrupting these life-saving treatments and prevention and treatments services when they're being arrested or incarcerated. And of course, we're all fighting for decrim now, right? So we'll talk a bit about that in later slides. So experience stigma or discrimination, and I just want to see this particular GAM indicators, global AIDS monitoring indicators, and I have my notes and I've lost them now. So this global AIDS or GAM monitoring indicator, which is indicator 6.5, talks about, when we talk about stigma and discrimination, this is, we ask the specific question as to whether people felt excluded from family activities because they inject drugs, whether they had been scolded because they injected drugs, or whether they had been blackmailed because they injected drugs. And you can see the proportion of people who had been stigmatized or discriminated against due to drug use just within the last 6 months. Pressing the wrong button now. There we go. Okay. People who had avoided healthcare due to stigma and or discrimination in the last 12 months. And I think just to highlight this GAM indicator as well, which is 6.6, the question asked to people as part of the interview here was whether people were afraid to seek health services, whether they were treated unfairly, or they were denied health care, or avoided seeking HIV services because they inject drugs. And you can see that huge proportions of people across all four sites were also avoiding healthcare seeking behavior. Nearly there. Sexual violence, sexual or physical violence in the past 12 months, you can see the same. I've just got the 3-minute reminders, so I'm going a bit quicker through my slides. Access to OAT or medication-assisted therapy, you can see that a small proportion of people had ever, or more specifically currently, been on OAT, and we know that this is also a life-saving intervention. We know that people who get onto opioid substitution therapy really manage to get their lives back on track. They manage to become productive. They manage to stop craving the opiates, and they kind of get this clarity in their mind where they're able to go look for jobs again and become productive members of society. And we can see that there really insufficient numbers of people are accessing that. Overdose, I'm not going to go too much into this, but just to say, again, as per James's presentation, you know, we really need to improve access to overdose services, particularly people being able to access naloxone in the community and not having to access it via clinicians at a public health, at a health facility. And you can see just some of the percentages of people that have overdosed on drugs between like 18 and 24% in some of the districts. So just in terms, and I think hopefully this will become clearer during the summit if it's not clear to those already, some of the conclusions and recommendations from our findings in the BBS. So we know that there is a massively high burden of HIV and hepatitis C. There are gaps in both the 95-95 treatment cascades and also the 10-10-10 social enabler targets. There are high levels of engagement with the criminal justice system, and with all the gaps that I've tried to highlight as part of this presentation, we do need to also try and focus on the silver linings and the successes that are evident within the programs so that we can build on those and we can get closer to reaching the targets that we're aiming towards. So some of our recommendations, and I think these are coming out over and over again, is that key population sensitization is important across the health system, and I think we'll hear more about that as we talk about the centers of excellence. Changes in practice amongst law enforcement. I tired out the sign language interpreter. Sorry. Changes in law enforcement and to continue to advocate for decrim. Increased overdose awareness and prevention, as well as mitigation strategies, which I think we've all spoken about or will be speaking about during these 2 days. Harm reduction, of course, and PrEP. And then for me, you know, viral hepatitis, my last point, Jabu, I promise. Viral hepatitis hepatitis B is preventable, so it's not as common in people who inject drugs, but hepatitis B is a major cause of chronic liver disease and hepatocellular carcinoma globally and in South Africa as well. And we should be preventing it with a birth dose of vaccination, and I could also kind of go on about that as well, but I don't think this is the platform. And treatment for hepatitis C really needs to become more affordable. We can cure hepatitis C in 3 months. We can cure hepatitis C and people can live healthy lives. Of course, they need to then have access to ongoing harm reduction services. But the fact that a 3-month course of hepatitis C is in the region of 30 to 40,000 rand at the moment is just really not acceptable, and we need to continue to advocate for better access to that as well. I think that's all, Jabu. Thank you very much. Sorry I went a bit over time, and thanks again.
Thank you, Joe, for that presentation. So I think we all now have the background as to how targets are set when it comes to implementers. It is because of the work that is done by such surveys, your biobehavioral surveys. So that's where we get the information. Previous presentations, especially from Richidze, they highlighted challenges that are faced by key populations, especially in terms of accessing services within healthcare facilities. So they came up with recommendations as well, and part of the recommendations was the establishment of centers of excellence. So what are centers of excellence? So let me call upon the expert that will talk about the centers of excellence. So Sister Mapasega, Mabena, we know a Sister Pasi, just to give us a rundown in terms of what constitutes centers of excellence. Over to you, Sister Pasi. Sorry, I forgot that I have to adjust. Are you okay? No? Is it okay?
Yes.
Should I go down a little bit?
No, it's okay. Thanks. Okay. It's still morning. Yes. A good morning to everyone. Can I close my laptop? Is there someone projecting for me? All right. Meanwhile, they are still fixing the presentation in terms of reflecting there. I would like to thank this opportunity to stand in front of you and present this exciting model of key population centers of excellence. And as you have heard, most of the previous speakers, were busy referring to the centers of excellence being one of the key recommendations in terms of ensuring that the access into the key population facilities is scaled up. And I must say it means today the word of the day is key population centers of excellence, right? That's our takeaway home, key population centers of excellence. And also, again, what I like about the key population centers of excellence is that it brings all the key population experts together, as well as not only the healthcare workers, also the social development department is also part of this, the justice system, the correctional service and department also. So the centers of excellence, they actually bring everyone into one room, ensuring that we treat this one individual, because at the end of the day, we need to ensure that this human being is serviced, whether they inject drugs or they work as sex workers and so forth. So this is a very, very exciting model that we are implementing. I can press it. All right. Right, so the background in terms of the centers of excellence is that to achieve the 95-95 strategy, the National Department of Health endeavors to provide comprehensive health services to the key population. And these services, they must address stigma and discrimination instigated by the healthcare providers and deliver targeted programs within the facilities to ensure that all key populations receive the services that they need. So this key population centers of excellence initiative is led by the National Department of Health and supported by PEPFAR through the Oram Institute and the VETS RHI. So the most important question, why the focus on the centers of excellence? Number one, evidence shows that the integration of services for the key population increases the uptake of the health services among this often marginalized community or group. Secondly, providing accessible health services for the key population has demonstrated a significant reduction in communicable diseases, including the HIV and the STIs. Number three, the integration of the key population friendly facilities, it is a sustainable and cost efficient, and it also strengthens the health systems while promoting the continuum of care. Lastly, South Africa's constitution, it protects the rights of all people to ensure that there is equal health access. I really wish this was projected so that you can see. Okay, all right. They say it's coming. It's coming, it's coming, it's coming. There it is. Okay, all right. Let us move to slide number 4. Okay. All right, so this was our previous slide where I was alluding in terms of, explaining why are we, focusing on the centers of excellence. And as you can see there, it's a matter of, equality versus equity. This is what we want to achieve to ensure that there is sustainability. Right, here's the slide. So The National Department of Health, has made it a priority to strengthen the key population centers of services in the public health facilities. And we are looking at the key population health implementation plan, which aims to develop and standardize these key populations programs within the public health facility. And we are looking into also establishing the key population centers of excellence in each province. So as James has said that the target is that we must at least have 8 facilities in each district that will be established as key population centers of excellence. And there needs to be ongoing mentorship, because as it has been mentioned that key population sensitization training has been provided for years and years ago. However, what is it that now we are bringing to ensure that there is sustainability? So we are also looking into issues of ongoing mentorship, hence why we need also the key population partners in around that facility that is being established as a key population center of excellence to be included and be part of that initiative and ensure that they support that facility until they have reached the excellent level. And then also, again, we are also looking into the issues of providing the IEC material and also the issues of also addressing the gender-based violence as well. And then lastly, also, again, we are looking into collaborating with the community-led monitoring through Richitse and the KP sectors. So as I have mentioned, that this is a very beautiful document that is aimed to standardize these key population programs at the health facilities and the community levels so that we ensure that we establish the centers of excellence in each province. So also in this one, I'm just going to run through as Jabu has presented that. Firstly, if you look into the first quadrant, which is quadrant number 1, which is exclusion. So this is what is currently happening in our communities, right there. So that is what is being currently happening in our communities right now. We've got a key population partners providing services privately, all right, or separately. But what happens to this client after hours? What happens to this client once you have packed your gazebo and got into a mobile and knocked off, right? So that is why we need to ensure that we invest in this and ensure that there is integration and inclusion within the public health facilities. So the Department of Health aims to integrate these services for the key population within the general health system. And also, again, we believe that this is a more sustainable model considering the resources that we have as a country. So this one it's one of the reports that were presented by James. So as you can see, a huge number of percentage of people who are being refused services in the public health facilities are people who use or inject drugs. So looking into the key population centers of excellence standards, of which I also believe that for us to achieve this and ensure that there is sustainability, we need to ensure that we integrate them with the ideal clinic standards so that the district managers or the operational managers can see that this is a required standard. Each and everyone working in the facility must ensure that these are achieved and it should be available. It's not a matter of choice or what. Right, so number 1, we are looking into ensuring that the staff is sensitized and we are covering both the clinical and the non-clinical staff. Also, again, secondly, it is availability of KP job aids in the consulting room. This is a very, very crucial aspect as well. And also, there needs to be availability of KP IEC material, including the posters. So we also want the posters of the KP partners who are implementing in that district to be available in that facility so that in the facility, everyone should know who are they working with within the community, and also to ensure that there is mentorship taking place. And also another recommendation in terms of this. My slide is not moving. Oh, sorry. Apologies, colleagues, on the 4th bullet. So another recommendation in terms of the standards is that we would like to ensure that at least there is one KP peer educator placed in the facility to support the facility, and also again ensure that they monitor the services that are taking place in the facility. And also, again, we need a KP representation in the clinic committee. We know that in our facilities, there are clinic committees, and it would be ideal to have a KP representation who would then be able to advocate further for the key population community. And then for now, we are saying we should be able to screen and refer for harm reduction. Underline, I'm saying for now, right? With these centers of excellence, they are also, it's sort of like a strategy aimed at influencing the policy change, right? So for now, we are saying screening and referral for harm reduction. However, in that facility, they should be able to manage overdose, right? And then maybe refer for safe packs, because we know that currently the public health facilities are unable to provide sterile needles and syringes to our peers who are injecting drugs. And then also, again, in terms of the screening and the referral for the gender-affirming healthcare services, also it is a for now, right? However, the healthcare providers who are working in that facility, they should be able to assist a transgender woman or a transgender man that works in that facility, and also be able to manage them accordingly and refer them accordingly until we are able to procure the hormones as a department and ensure that they are available. So these centers of excellence will be also used as sort of like a benchmark for other facilities who will then establish more centers of excellence, so that at least we know that this is a standard. So that is why we need them to be ideal clinic standards. And also, again, there needs to be screening and tracing and management of mpox, as we all know that we are currently having mpox as a country, so we need to ensure that this is also managed. And also we need to ensure that there is competent staff to provide these services to the key population. So that is why we need to emphasize on training and ongoing mentorship. And lastly, there needs to be a discrete, safe complaint system, because we know that right now we do have those beautiful suggestion boxes, a pen and a paper whereby you write, but now we need to, further accommodate individuals who might not be comfortable to complain in the facility. And then that is why we need to ensure that the quality assurance as well of the Department of Health also comes in and collaborates with us to ensure that there is an effective, discrete, and safe complaint system. So to date, we have a total of 113 facilities that have been identified, and as you can see, Gauteng is leading with 38 facilities. So, I must say Gauteng is one of the most effective provinces, and they respond accordingly. I'm not sure, is it because of the KP partners working in that area or what? However, work there is being done, and also followed by the Eastern Cape as well, and Mpumalanga, KwaZulu-Natal, the Free State, the Northwest, and the Northern Cape. And we are also to wish to be able to identify more facilities in the Limpopo province. As you can see, Limpopo is not reflected there, as well as in the Western Cape. So I'm hoping that in this platform we have a representation from these two provinces that will assist us in terms of forwarding this message to the Department of Health in these two provinces to say, please, please, we request them to respond into this initiative. So as you can see as well, our trainings are not only focused on healthcare workers working in the facility, we are also targeting the peer educators. So as you can see, most of the peer educators that have been trained are from the Free State province. I must say the Free State province as well is doing very, very, very great. And it's one province that has got more peer educators. And I understand that Global Fund is leading mostly in that province, so well done, guys. And also, again, we are also expanding our training to the district supporting partners, because we believe that these are the partners that are implementing in the facilities and would be present to ensure that there is definitely sustainability taking place. Now, this is my last slide. When it comes to the established key population centers of excellence, so in the previous COP, we have established 10 facilities. So this COP also, again, we have 11 fully trained facilities, and we have proposed launch dates. And I must say, expect an email or an invite from myself, especially all the implementers in this room should be part of these facility launch activities, including Rechitse, to ensure that we sensitize the community and, demonstrate that this is a need for our key population community. Thank you. Short and sweet.
Thank you, Sister Pasi, for rounding up this session. So colleagues, there we have it. We heard from the beginning from Ms. Sibego, who gave us the overview in terms of KP programming in the country. We shifted the gear where Comrade James gave the state of the healthcare address, followed by a population-specific biobehavioral survey, and we kept it with KP Centers of Excellence presentation. So in a nutshell, that was the presentation. May you please help me to give a big round of applause to our panelists. Thank you once again. May I call upon Yolan just to give us the breakdown of the parallel sessions that will be taking place from now until lunchtime.
No, people shouldn't grow. You should stop growing. That's what should happen. You should stop growing. Afternoon, everybody. And can we just say again a warm thank you to the panel for those amazing presentations. So we have the breakaway sessions that will be happening after tea. We do recognize that we're quite over time, but we want to be respectful to harm reduction and allow people to have their tea. So I believe, Jabo, if it's okay with you, we'll restart the breakaway rooms from 12:30. So it's 12 o'clock right now. There will be breakaway rooms. There's track A and track B. All activities for track A on the agenda for today and for tomorrow will be in OR Tambo room 2, which is just next door to the plenary session. So straight after tea at 2:30, we have the health services access and quality, identifying barriers and solutions, moderated by myself. And we have representatives from the National Department of Health as well as from SANAC that will be speaking in terms of the access to treatment and commodities. Then all track B sessions from today and tomorrow will actually be in King Shaka's room, which is outside of this venue by domestic. So as you come out by the front door, to your left is domestic and the King Shaka room is there. The next session is a very exciting session. It is the community engagement and empowerment, networks involvement in policy change and programming. And we actually have from the Key Population Network as well as implementers from Sandput, Sisonke, Out Wellbeing and Rofe Community Services speaking there. And it's moderated by Pilisande from TB HIV Care. So colleagues, just once again a reminder, all track A will be OR Tambo room 2. And we have a session from 12:30, and the other session is in track B, It is in King Shaka Room by Domestics. So it's parallel sessions. You are welcome to join the sessions that interest you, and we'll see you later. Thank you so much. If I may just ask 3 people to maybe stay in the room if they don't mind. I'm pulling this person out. If it's possible that Helen Sava can stay in the room, as well as Klaas from Sandput and Koli from Sisonke can stay in the room, we would greatly appreciate it. Thank you, everybody. Enjoy your tea.
Lusa, awesivula, besitsheka, ekhoshe noma besivula, besiyela.
Thank you.
Kubi, kubi, kubi ya, kuisiyaya.
Danko, danko, danko. Siyabonga. Our commercial breaks are always lit, right? Thank you, thank you, thank you. That was more than an energizer, especially coming to this graveyard session. I think we are all energized. Thank you very much. Thank you. So this is the opportunity for us colleagues now to at least get an idea of what transpired in different breakaway sessions. We were divided. Some wanted to attend both, but they couldn't. So this is the opportunity just to get a summary in terms of what transpired in different breakaway sessions. So we had 4 breakaway sessions from just before lunch up until a few minutes ago. So I'll be calling moderators or people that were chairing the sessions just to come up and give a little bit of summary in terms of what they got out of the sessions, what were the key take-home messages, and are there any recommendations and stuff. So without wasting much time, I'll start with the first breakaway session, which is session 1, where we were looking at health service access and quality, identifying barriers and solutions. And may I call upon Yolan to share what transpired. Thanks. We're disabled, some of us.
Hi. It's not shortness is not a disability.
I said us, you are tall.
Oh, okay. Thank you so much, program. It still feels a bit high, yeah. Sorry for those that are taller that comes after me. You know, someone said to me today, "You're glowing." They said, "You're glowing." So I said, "I'm sweaty," because I was running around. But actually, and I say this, I used to work in the sex work program. I used to work with transgender communities. I used to work with people, I work now with people who use drugs. That cuts across the LGBTQI community, it cuts across sex workers. And today, I've never been so proud. I have never been so touched. I think you of all people understand how much this means to us. It really does. So thank you for coming in your numbers. And I'm actually not doing the thank you speech, that's trouble. But I just wanted to express our gratitude. And I speak for my colleagues, but I also speak for the NACOSA team. Thank you so, so much for being here and having your voice heard. From our session, which was a great session, but what really came out very clearly is we need a follow-up. And we need a much longer follow-up. Our focus was on access to healthcare services for key populations based on what is proposed in the new grant cycle for Global Fund, but also from our program experience from PEPFAR sites, from COSAP, from Global Fund sites. We know where the gaps are in terms of key populations, and we were very grateful to have 2 representatives from National Department of Health and also from SANAC as well in terms of the health products specialist. But what was clear to us is that we need to address certain issues that did not come up. And one of them was specifically in terms of hormone therapy for transgender people and gender-affirming surgeries that are critical, that people are waiting on lists and they are losing hope. We know that there needs to be a sustainable program for needle and syringes, because right now we are relying on Global Fund and PEPFAR and COSAP to make that happen, and that can't be the way forward. It can't, guys. Not if we're going to address the goals within the National Strategic Plan. So in terms of our session, the key points that came up was cost of commodities. Even the National Department of Health said that they are struggling in terms of diagnostic tests, in terms of the cost as well as the treatment. We all recognize that community-based models works. You, as implementers on the ground, are saving lives each and every day. So thank you to all of you. We also looked at the scary scenario of sexually transmitted infections. We all focused on HIV. We're not focused on all the other sexually transmitted diseases. And it's particularly having some severe effects in terms of our MSM community and transgender community, because so few anal cancer screenings are available at a community level. We are very much aware of hepatitis. We know that within the injecting community that we work with people that are on methadone, we already have an 83% hepatitis C prevalence. 83% of the people that's on methadone. That's never mind the 87,500 people that still haven't been screened for hepatitis C. So the reality is that we're sitting with medication that is approximately 30,000 Rand per patient for a 3-course medical treatment. And where are we getting the money for that? So I think from National Department of Health as well as from SANAC, it was very clear that we need to be looking at price benchmarking and advocacy from a community level about the treatment affordability for key populations. And this doesn't just refer to hepatitis, but also in terms of injectable PrEP and other vaccines that are required. We recognize as well that we need to scale up sensitization of healthcare, because it doesn't matter if we have the treatment available and the services available if people don't want to walk through the doors because they don't feel supported. They don't feel like they're going to receive the services that they need that is appropriate for them. And then the last few points is that we need to strengthen the treatment adherence, because we do have situations where people are coming for treatment, they come in and being diagnosed, they start in treatment, but they don't complete it, and it leaves a negative effect for the next generation of babies that are born as a result. And then also with regards to the main point is, where is our partnerships? We're all sitting in the room. People need to start looking at us as experts in the field and recognize that we bring a lot to, service delivery at a community level, but also at a district, provincial, and national level. And more of our voices need to be heard. More of us need to be involved in policy making, in guidelines development, and program development and delivery. Thank you very much, guys.
So, colleagues, I'll call upon track 2 in terms of our breakaway session. And may I call upon Pilisande Madosi from TBHIV Care just to walk us through the community engagement and empowerment session.
Good afternoon, colleagues. So our breakaway session was community engagement and policy change in programs. So our reflections or take-homes from the discussions or the deliberations we had was the current need to strengthen collaborations as implementers in place. We are exposed to these platforms where we come together and we network and we engage, and we need to follow up on our engagements instead of bringing more engagement platforms instead of trying to find a common solution. And also, we have emphasized on also policy dialogues, which are currently taking place. And also, we need to enhance those to ensure that there's health inclusion for policies for key populations. And then also, we touched on engagement with community leaders, government, religious, and also traditional authorities, because everything starts from the community level. So if we are trying to push forward in terms of key populations, our traditional leaders, our community leaders at large, they are the first people actually to ensure we reach all the right population, and also to ensure there's adequate services to key pops. And then also we spoke of the need for network member leadership capacitation, so that when they're part of policy engagements, they are equipped enough to ensure policy design and also to ensure engagements are fruitful. And we also spoke of challenges in structural barriers, where we need to ensure that we have these sessions where there's legislative people who are also part of these platforms, and also we capacitate our network leaders as well to ensure that they are part of legislation platforms. And also, what we also spoke about was the integration of human rights violation policies that we need to speak of, and also to improve health services and accesses for key pops. And what was common as well out of all the sectors was we are all collaborate already. We all have a unified voice, and we need to actively participate in all legislative areas to ensure that our mandate is actually gets to the right people. And also, we touched on there's currently organizations that are currently busy with also policy reviews, for instance, the methadone programs. So currently, there are OST programs, or even people who are using drugs that still don't have access to OST. So it is our responsibility to ensure that we provide or we engage in these policy reviews to ensure everybody receives access. And also what, lastly, we spoke of, in terms of the theme for our engagement, was actually social inclusion and also policy inclusion for key population and platforms where they are not currently at. Thank you.
Thank you very much. And we had the afternoon parallel sessions, and the first session looked at stigma and discrimination in healthcare. We're basically looking at reducing stigma and creating inclusive environment, and this was chaired by Dr. Pulu Ramotwala. So may you please come and give us your thank you.
Thanks, Ed. I am considering that PhD. Good afternoon, colleagues. So we did the stigma reduction in a healthcare setting, and we had two speakers, one from talking about centers of excellence, and then we also had Human Rights Commission. We're expecting Home Affairs to be part of the discussion. Unfortunately, they were not part. So what we looked at, the context of our discussion, we included looking at a goal 1 of the National Strategic Plan on HIV, TB, and STIs, which is around breaking down barriers. And if you look at stigma and discrimination, it's about breaking down barriers that prevents key populations from accessing services. And I just want, I'm now being opportunistic under breaking down barriers. Objective 1.3, if you understand what the NSP wants to do, look at objective 1.3, which is about reducing stigma and discrimination. So when it comes to centers of excellence, I think it was clear. The questions were around wanting to understand more how the centers of excellence work, and then specifically trainings, ensuring that key populations are involved in those trainings. It is happening. Then the recommendation was that there should be some kind of a scale-up, making sure that we continue to have key populations participating in sensitization of healthcare workers around stigma and discrimination. So we talked quite a lot around
healthcare workers, the roles that they play at healthcare facilities, and again, using the model of centers of excellence. But we know that centers of excellence is just a portion of facilities that are available nationally. So how do we make sure that the standard or the services that is maintained by centers of excellence is also included, goes beyond those centers? Okay, we talked about including KPs. Then most of the discussion was with the Human Rights Commission. It was clear in that group that the Human Rights, a lot of us, even myself, didn't know how the Human Rights Commission work. And then at national level, the Human Rights Commission is known, but at provincial level, it depends on which province you're from. It was clear that some of the provinces, the provincial offices are not functioning, and we got a commitment from the Human Rights Commission that they will assist to link us up with some of those provinces. So I think it will be up to the provinces to also follow up when it comes to Human Rights Commission. It was also clear they projected some of the data that they have from the previous financial year. Their biggest cases are from health, are health related. The second and highest number of cases are around equality. So they are dealing with issues that we are dealing with, and we've also got a commitment from them to engage us at national level in order to ensure that the issues around of key populations, they are taking up further. Then there was questions around some of cases by Human Rights Commissions being rejected or not being followed up, or some, I promise, I'm going to say it here, they are rejected, ne? The Human Rights, the LGBTQI cases are not being processed. Happy ending, yes, I would need it. So she was saying that the cases don't have happy endings, so how do we make sure that those cases that are not dealt with by the Human Rights Commission are followed up, especially for key populations? And then also around decriminalization, we got a commitment from the Human Rights Commission that they are still prioritizing decriminalization of sex work, and the new commissioner has indicated that they are committed. So, Koli, yes. So perhaps that's something to follow up. I think I'm not sure about those who were in that room around people who use drugs. I thought the answer was a bit gray. So it will be good to kind of follow up in terms of how the commission is supporting people who use drugs. And I think the Weinberg case was a good example. Yeah, I did mention that they are prepared to work with key populations, and they have requested that we update them and perhaps invite them in some of the sessions that we will be having. Thank you.
Thank you once again. I think that session kept the day for us. So we had a very interesting day. But before I get to that, we had a session that was very riveting, if I can put it like that. Everyone was engrossed and everyone wanted to talk and everyone wanted to be part and parcel, and that was the topic of mental health. So that's a key issue within the key population space. So I will invite Weitumelo from FPD just to give us reflections around mental health and well-being, where you were focusing on addressing mental health challenges for key populations as well as healthcare workers. Over to you, Weitumelo.
Good afternoon, colleagues. So as mentioned, our session was quite a heavy one. Mental health, it's really not a light conversation to have. So it was on mental health and addressing the issues faced by key populations as well as healthcare workers. So a lot of issues were identified during the session by the panelists that had the common theme of stigma. Our key takeaways is that there is definitely a lot to be done to ensure better mental health care for all, And this cannot be done without a multi-sectoral approach. One of the themes of the summit is that we need to work together. So the same has to be done for mental health. We need to advocate for better mental health care of key populations, and this can be done through sensitization and capacity building of healthcare workers, sensitization of our communities, our faith-based leaders, and most importantly, members of our household, because the truth is mental health care begins at home. So we are now mandated by the NSP to integrate mental health into services for PL-HIV as well as key populations. I repeat, we are mandated. I believe we had a lot of experts in mental health in the room, but due to time constraints, we couldn't get their inputs. So we definitely need a follow-up as well. The conversation cannot stop here. Thank you very much.
Thank you once again. I think we all have got an idea in terms of what transpired in different parallel sessions. So it was a heavy day, but I think we managed to fulfill the mandate of why we were gathered here today, part of which was to share lessons, best practices, worst practices, you name it. And the idea is to share information. So we started off with introductory remarks, which actually brought everyone into the perspective of this particular workshop. So we got the overview. Once we did that, we moved down to specifics, whereby we were looking at the role of data, for example, in terms of how the health setup for key populations is currently structured. And then we then broke it down to look at different sessions, where we had parallel sessions, of which you've just received the summary from the moderators. So that being said, I think it keeps the day. I heard someone saying that HRVs, they don't, human rights violations, there's no happy ending. But I think for this one, after such a long day, I think we're going to have a happy ending. So I'll call upon Yolande just to give us just the rundown in terms of our happy ending, how it is going to pan out. Thank you.
Actually, I'm on my tippy toes here. The acknowledgement should actually go to AIDS Foundation of South Africa, to AFSA. They've put together a beautiful event after this. So maybe they can speak to the arrangements, but you're not excused. There is a happy ending for at least one of us, after this. But the reason why I've asked to speak is because there's certain people that promised me stuff, and I'm going to hold them accountable. So there is, AFSA, if you would like to share what's going to be, your event at the Serengeti. But from our side, in terms of the program, we have a song, a beautiful song that will be sung by Ayanda and her team from TB HIV Care, from the PWID program. We also have a prayer from Nkunzi, who is from the PWID program. We will have some tributes from key populations. So I'd like to acknowledge Sisanda from TB HIV Care that will be talking, Lucky Boy and Penny, as well as from the PWID sector as well. And then we'll have a song from the sex work team coordinated by the Center for Positive Care. And then lastly, we have our vibe, which is obviously, Kamalo, like Sibo. He's going to be bringing on the vibe in the end. But we want to also pay tribute to a wall of remembrance for those that are fighting and have lost the fight in terms of the key population community. So please don't run away. Spend that time with us in the end so that we can pay tribute to them. So thank you so much, Edward. But also, can we just please give a hand of applause for AFSA, who has coordinated the beautiful, happy ending that you will have. Okay.
Hey, can I have someone from AFSA, please? Chris, where are you? Or Sophie, please. Sex work is where?
Work is work. Good afternoon, colleagues. It's a very short announcement. After this session, we have arranged a very nice networking and socializing kind of a session, not very far from here. You know where you had lunch? Just behind. So even dinner would be served there. You don't need to change, there's no dress code, isn't it? Yeah, you just come as you are. And then let's all celebrate. Thank you.
Thank you, colleagues. I told you there will be a happy ending, and it's setting in. Okay, just before we call it a day, may I please just remind you about tomorrow. So if you check your programs there, it says we start at 9:30, but tomorrow we want to also break off a bit early. So may we please start our session tomorrow at 9 a.m. Please, may we be seated by 9 o'clock a.m. tomorrow. So that being said, it's a wrap. See you later.